See, always we do FFR in non-MA patients, we see that when we do revascularization. But here it's been a different scenario that FFR and multivessel disease, especially in ACS. And why we have to consider FFR, and one thing is we have to know that whether FFR is reliable in ACS. That's the first question. The second question is FFR is safe in ACS, and is there evidence there? And is it been a cost effective for our whole entire procedure? So when you go back to the physiology, and you know the thing, culprit vessel and non-culprit vessel, when it's been a STEMI or especially in STEMI, there will be definitely systolic and diastolic dysfunction, and as well as the changes in vascular tone during reperfusion. There will be a tachycardia and bradycardia episodes, microvascular dysfunction, and as well as distal embolization and hypoxia and myocardial stenting, which has been quite common. So these are all the things that are common physiology will get into the picture when we do the FFR. So when we see the non-culprit artery lesion, when in ACS, always there will be it's a pan-inflammatory process and as well as a pan-vasoconstrictive process. With all this physiological background, I would like to say that what is the practical concerns doing FFR in ACS. Always it will increase the procedure time and as well as increase the contrast volume. And we know the thing, adenosine usage, it has its own complication and contraindications, and there will be FFR wire-induced complication and cost of FFR and subsequent additional PCA, the cost. So everything plays a role when we come to the practical concern. So it's almost like oculostenotic reflex. So FFR and non-culprit, see where it has started. It started in 2010 in Japan. So where they have enrolled all the ACS patients, especially STEMI and NSTEMI, and they have done a FFR at the baseline, FFR at the time of ACS, and after the mean time of 27 days to 30 days of a period, they have done a FFR. So both the STEMI and NSTEMI patient, there is no difference in FFR of the baseline ACS FFR and as well as the 30 days FFR, there is no change in that. But as I told you in coronary physiology, we have the microvascular dysfunction. All the studies so far which has been come, it says that there will be a microvascular dysfunction. It will be there in a non-culprit vessel up to probably a 3 months duration of time. So this is a little bit contrary in this study. But even though the absence of changes in microvascular function, the reported by the Japanese group as relatively short as like the other studies which have been having a microvascular dysfunction. So it says that probably within 27 days they say as a mean period, but the microvascular dysfunction may up to 3 months, it may last long. And so when we come to the real picture, so we have, whenever we see a STEMI patient, we have a three group we can actually make it. One is aggressive PCA, we can do the PCA, multivessel PCA at the time of STEMI itself. Another thing is intermediate PCA, that is culprit vessel PCA, followed by within a hospital admission, we can do the remaining vessels, we can do it. And the conservative one, which has been a culprit PCI, then followed by elective PCI if symptoms or ischemic components being warranted. So with the base of these three category, all those trials so far it has come. So either a primary trial or a culprit trial or a dynamic 3, the primality trial or a comparative trial. So now we'll move on to the primary trial, the primary trial. So here the revascularization is based on the angio, that is at the initial time of ACS itself, and the conservative group. So they have been compared both the ischemic driven peripheral and as well as the primary PCA with revascularization based on the angio. So they say that the overall the death rate of cardiac causes non-fatal myocardial infarction and as well as the refractory angina, the p-value is reasonably significant. It says that only the p-value which has been significant for the cardiac causes non-fatal myocardial infarction and refractory angina. But if you take it individually, but it is not playing the major role on that part. This has been published in 2013 in NEJM. And when you move on to the, that is dynamic 3 primary multi FFR day 2 trial, that means the patient will undergo the primary PCA for the culprit vessel, and the non-culprit vessel will be taken care of within 24 to 72 hours of the period, that is during the hospital admission. So where here is the real revascularization is based on the FFR, that is intermediate one, and the conservative which has been confirmed, which has been ischemic or the symptom oriented PCI. In this, they have made a definition that whenever there is a significant coronary artery disease, more than 50% diameter or FFR of less than 80 or more than 90% stenosis, they take into the picture. So in this 314 patients they have taken up, where there is a 31 patient had the 31% of patients had a more than 0.8% of non-infarct related arteries when FFR is actually negative. So hence they were not revascularized. So only about very minimal people being underwent CABG, and as well as the unfeasible PCA is very less. So what does it say? It's a dynamic 3' will say again, it says that ischemic driven revascularization, which has been quite significant, which has been the 40% urgent revascularization can be reduced by doing the complete revascularization during the first admission itself. I think that will be the better. That was the dynamic 3 primality study says. And if you go to the sub-study of the primality study, it says that if you have either 2 vessel or a 3 vessel, which has been a more than 90% stenosis, definitely when you compare with all the 2 vessel, 3 vessel less than 90 degree stenosis, the composite endpoints were actually not much significantly, very much significant. This has been published in the recent one, the 2017, and if you look at this one, you can able to see the clear data that there is a presence of 2 or 3 vessel disease which has been a non-infarct related artery stenosis, which is more than 90%, definitely that we. So this is a sub-study of dynamic 3 primality. And there is one more trial which has been a comparative trial. Here they have done the 3 things which has been a very important point here. Most of the STEMI patient undergoing the PCA were randomized into the FFR and as well as versus the infarct related only revascularization here. This is only purely complete revascularization by FFR. And another thing is ischemic driven and as well as symptom driven. So here non-infarct related coronary arteries with the FFR were less than 0.80, and PCA most of the patients were here preferable the stents being a everolimus eluting stent, and as well as the index intervention is around 83%. During index hospitalization preferably within 72 hours. That means they have done a PCA within the index period itself, that has been a maximum 83%, and within 24 to 72 hours which has been a 17%. So here they have taken up 885 patients of multivessel STEMI, and where there is a 1:2 ratio which has been followed. And what does it say? It says that it's very simple. The procedure details of compare acute trial is very simple. That is, when you compare with the regular culprit vessel PCA timing, there is not much difference between the timing, the 6 or 8 minutes of time for the extra vessel doing the another PCA, which has not been a much difference. And another thing is when you compare with the contrast, so they have used average contrast around 202 cc for the infarct artery and 225 cc for the non-infarct related artery. That means another 30 ml of contrast has been extra, has been used. And FFR is successful in both the things, infarct related and non-infarct related. The FFR both almost equal. And here you can see that
Dr.
primary
Mohan.
outcome.
Dr.
So
Mohan.
Primary outcome
We'll have to.
NACE.
Yeah.
That's very important. The complete revascularization, those have been done with the FFR guided, which has been a more beneficial. That is the MACE-free interval is very, very high. So when do you not to do a FFR? Say in dynamic trial and unsuccessful infarct related artery, cardiogenic shock, stent thrombosis, and where there is indication for CABG and increased bleeding risk, those all the things they have not done. And another thing in acute comparator, again the same thing, TIMI1 flow or again infiltrate related artery is not done well, and left main disease and severe suppose valvular heart disease or clip 3 to clip 4. So there is one more study which is on the press actually, that has been an STEMI trial. That has been IFR comparing with the STEMI, and actually still not yet been come. It is in the press as of now. And so the take home point says, it says that half of the patients, those who underwent the STEMI with FFR patients, there have been a FFR of less than 0.80. The remaining 50 been more than 0.80. So only thing where they will be more benefitable is where there is more than 90% of the lesion. And if the 2 or 3 vessels been involved, definitely you can do the PC on the same sitting. And without FFR guidance, chance may be the revascularization may be reduced. Without FFR may be a little bit difficult. And another thing is the change of guidelines by using FFR in acute MI maybe a little later on may come in the guidelines itself. And another thing is the FFR guidance enables always the revascularization of the primary PSA to be good. So that's my take home point, and thank you very much.